honored chairpersons and distinguished audience. Today my topic is native vessel PCI through graft vessel. 59-year-old lady admitted with severe central chest pain with ECG changes and diagnosed as a case of NSTMI, early LVF and paroxysmal AF with first ventricular rate. She is a known case of status post CABG, Lima 2 OM1 and Lima 2 diagonal and LAD in India 1999. Status post PCI to RCA in 2004. Her cardiac risk factors are hypertension, dyslipidemia and CKD. ECG showed STT changes in anterior wall and echo showed anterior wall hypokinesia with mild LV dysfunction, EF 45%. And troponin I was more than 11,000 and creatinine 8.03. After stabilization the patient, we went for CAG. And CAG showed native TVD with ISR in RCA and graft vessel SVD. This is the angiogram. Left main is diseased, LAD totally occluded from its proximal segment and has tight stenosis, and LCX totally occluded from its ostium. RCA is dominant and good caliber vessel and has got 80% ISR from its proximal to mid segments. Lima 2 LAD and diagonal graft patent with 80% stenosis at native LAD. Lima 2 OM graft is occluded. And now, what will be the treatment option? As Lima is tortuous and usually prone to spasm, we advised for redo CABG. But surgeon refused to do redo CABG. Due to continuous chest pain, we opted for PCI to RCA and LAD distal to the graft. And patient party was also enthusiastic to go for PCI, taking in account with any type of risk. And RCA was engaged with the guiding catheter GR 3.5 6 French. Cyan blue wire was crossed the lesion of RCA and pre-dilatation was done with 2 into 20, 2.5 into 23 and 3 into 10 millimeter balloons successively. RCA lesion was stented with a 3.5 into 48 millimeter DES at 14 to 20 ATM. Post-dilatation was done with 4 into 10 millimeter balloon at 14 to 22 ATM. And final angiogram showed RCA was well dilated with TME3 distal flow. Now Lima was engaged with guiding catheter IMA 6 French. The cyan blue wire was crossed the lesion of Lima to LAD and pre-dilatation was done with 2 into 15 balloon at 8 to 10 ATM. After pre-dilatation, lesion was well prepared and proceeded to put stent. LAD lesion was stented with a 2.25 into 24 millimeter DES at 12 ATM. Final angiogram showed LAD was well dilated with TME3 distal flow. In conclusion, Lima is very prone to spasm due to its anatomical courses. PCI of native LAD via Lima to LAD graft is complex interventional procedure. Stent delivery and positioning through Lima to native LAD is crucial. Stent may stuck at the anastomosis site, thus may lead slow flow, no flow phenomena. Since Lima is very sensitive to spasm, IVAS advancement may be difficult in certain circumstances, especially in a tortuous Lima. In our case, Though lima is not much tortuous in course, we did not perform IVAS pre and post. PCI of native vessel via graft vessel is a complex interventional procedure, carries a lot of risk with complication like dissection, perforation, and hemopericardium. Operator skill and experience are very important for a successful PCI in post-CABG patient, where native vessel has advanced disease than compared to CABG time. Take-home message is pre-procedure planning is very important. Supporting devices must be kept ready in hand for any emergency to tackle. If needed, hard team decision can be taken prior to proceed for intervention. Lesion preparation, analysis, required stent sizing is very important. I acknowledge my gratitude to my mentor, Professor Shahabuddin Talukdar sir, for giving me the opportunity to present the case here. Thank you. Thank you for your patience hearing.